Welcome back to our third and final day of Road to Resus. I'm Ashley Liebig.
The past 2 days, we've been managing a woman who was critically injured in a motor vehicle collision. She's required a host of life-saving interventions pre-hospitally and in the emergency department. She sustained serious injuries in her chest and in her abdomen, but thanks to your excellent resuscitative decision-making, she survived a series of operations, and now she's in the ICU.
So she's not bleeding anymore, but some hours after her operation, she has developed sepsis, and in the last few hours, severe sepsis. Her blood pressure and urine output are decreasing despite aggressive vasopressors, and we have given her broad-spectrum antibiotics. So now we have this young, previously healthy woman in septic shock after an aggressive trauma resuscitation.
We have 2 ICU management controversies for you guys to simultaneously consider today. For this young woman, now in refractory septic shock, should she be treated with hydrocortisone, and also should she be treated with a metabolic cocktail, thiamine, vitamin C, steroids?
So we've been fortunate enough to have Rob McSweeney reach out to some of the very best in the world that might have a little bit of thought on these very topics. So we'll turn it over to Rob.
Hello, greetings from Titanic Belfast. I'm Rob McSweeney, an intensivist working in the Royal Victoria Hospital, just a couple of miles across town. The steroids and sepsis controversy has been raging in critical care for decades now. Our practice is dominated by 3 large trials published over the last 20 years. In 2002, the original ANAN trial compared Hydrocortisone plus hydrocortisone with placebo in patients with septic shock. Those who were non-responders to a corticotropin trial had improved mortality. The next trial was the Corticus trial in 2008, which compared hydrocortisone with placebo again in patients with septic shock. This failed to confirm the mortality benefit of the original ANAN trial, although it didn't have Hydrocortisone. Interestingly, corticotropin test wasn't beneficial, and also there was an increased rate of superinfection with the steroid therapy. The COVIDS trial in 2010, in a factorial design, examined the efficacy of fludrocortisone in addition to hydrocortisone. Again, no benefit was found. So, of the 3 large trials, we have 1 trial demonstrating improved mortality with a combination of hydrocortisone and fludrocortisone, 1 trial demonstrating no improvement in mortality with hydrocortisone, and 1 trial demonstrating no improvement in mortality with fludrocortisone over hydrocortisone. Confused? Me too. So this brings us to the 2 big sepsis trials of 2018. The adrenal trial, first results of which were presented here in Titanic, and the Apricus trial, which we also had discussed here just a few weeks ago. To put this in perspective, the original 3 trials I mentioned had recruited a combined total of 1,100 patients. Adrenal and Apricus recruited together almost 5 times that amount. To help answer the question as to whether we should use steroids in the management of this young woman now with septic shock or not, I've asked a few friends for their opinion. First up, we have Professor Balavantakash from Brisbane. He was the chief investigator for the adrenal trial, so it'd be pretty interesting to hear what he has to say.
I believe this patient will benefit from hydrocortisone as she has septic shock and is mechanically ventilated. Although its role in reducing mortality is not clear, there are clear important benefits in patients and secondary outcomes, such as faster shock resolution, such as earlier liberation from mechanical ventilation, and faster discharge from intensive care. You could use hydrocortisone at a dose of 200 milligrams per day. You can give it as an infusion or in divided doses for a duration of 7 days. And there is no need to perform a corticotropin test. There is no need to taper the dose of hydrocortisone after the 7 days. And I wouldn't be using fludrocortisone in this situation as the evidence for that is not conclusive.
Let's hear from someone who works in a slightly less well-resourced healthcare system. Professor Flavia Mercado is well known to everyone there at SMAC. She works in Sao Paulo in Brazil, which is recognized as a middle-income country. Let's hear what Flavia has to say about the use of steroids in septic shock and whether she's likely to use it, given its possible beneficial effects on resource utilization.
Hi, SMAC community. I would give corticosteroids to this patient because although I'm not sure that she fulfills the criteria of ANAN studies so she might not benefit in terms of mortality. I do value the secondary outcomes of a adrenal study. Reducing time of ventilation and length of ICU stay are important things, even more in settings like mine, where there is a possibility of ICU beds. I will give 50 milligrams every 6 hours because I'm not sure that the bolus infusion is better. Maybe because it's associated with less adverse effects, but it might also have less effectiveness. I would not give fluorocortisone because all these studies have shown that corticosteroids reduce the duration of vasopressors, so I don't believe that we need it. Thank you.
Next, we'll hear from Dr. Manu Shankar Hari. He's an intensivist in London and was part of the team which recently published a meta-analysis looking at steroids and septic shock in the BMJ.
For the clinical scenario described, I wouldn't start corticosteroids at this stage. The reason being, the risk of death with post-trauma related septic shock is way lower than sepsis and septic shock getting into intensive care unit. Now, if the patient's condition were to deteriorate, then definitely I would start corticosteroids. What do I mean by deterioration? If there's an increase in norepinephrine dose greater than 0.6 mics per kilo per minute, I would definitely consider corticosteroids. The evidence for corticosteroids to improving mortality outcomes is uncertain, whereas it definitely will improve the duration of shock.
So we've heard from the others. What do I think? So if I were managing this patient, would I treat her with steroids for her septic shock? Yes, I would. The reason I would is that from the two big trials of 2018, Adrenal and Apricus, there's a clear signal that these therapies are safe, they speed resolution, and they may well have a mortality benefit. In addition, they're cheap and they're readily available. Also, these trials are contemporary, whereas the previous trials go back as far as 2002. For those reasons, I would use fluorocortisone and hydrocortisone in the management of this woman's septic shock. Professor Paul Marek from Norfolk, Virginia in the USA developed the metabolic resuscitation strategy of vitamin C, hydrocortisone and thiamine. He presented his results here for the first time in Titanic Belfast. This has proven incredibly controversial. This was a single-centre retrospective before and after design which investigated 47 patients managed with his new intervention of hydrocortisone, vitamin C and thiamine, and he compared it with 47 patients managed in the previous 7 months without this therapy. Mortality fell from over 40% to 8.5%.
I could present at this meeting, and also we felt that we had an ethical imperative to spread this data, because I think this saves lives. And I think that there may be skeptics in the room, but as I'll show you, it is completely safe. You have nothing to lose except a surviving patient. You can see in the control group, the mortality was almost as predicted, 40%. The mortality in the treatment group was 8%, which was 3 patients. Those 3 patients left the ICU alive, off presses, off a ventilator. They had severe end-stage Alzheimer's, severe sarcoidosis, and severe cardiomyopathy, which we didn't know at the beginning. Those patients had their treatment withdrawn. They did not die of sepsis or sepsis-induced organ failure.
Few interventions have caught the imagination as much as this intervention has for the entire critical care community worldwide. At present, there are over a dozen new randomized controlled trials registered with clinicaltrials.gov investigating this intervention. The design of Paul's study unfortunately puts it at high risk for confounding. So many people are waiting to see the results of these new randomized controlled trials before changing practice. However, not everyone is, and given the possible and probable good safety profile with this intervention, it's unclear as to whether people should use this as a rescue therapy in patients otherwise continuing to deteriorate and not respond to their conventional management. I've also asked Paul Young, an intensivist and trialist from Wellington, New Zealand, well known to everyone there at SMAC, whether he would treat this young lady with septic shock with the Marek cocktail of thiamine, vitamin C and hydrocortisone. Let's hear his views.
Hey, so Rob, I think that vitamin C, hydrocortisone and thiamine might be the greatest example ever of novelty bias taking the world by storm. I don't know if this treatment improves patient outcomes or not. And so for me, under conditions of uncertainty, the best treatment is randomised treatment. So I would enrol this patient into the vitamins trial. It's a randomised controlled trial of hydrocortisone, thiamine and vitamin C that were running in Wellington Hospital ICU. We have in fact enrolled a number of patients in this trial, and I've noticed that some of the patients who receive vitamin C live, and some of the patients who receive vitamin C die, and I haven't really noticed any miracles, to be honest, but perhaps that's just a reflection of my own biases.
Finally, I asked Professor Karen Amrine, a friend and colleague from Graz in Austria, as to whether she would treat this patient who has now developed septic shock and has failed to respond to therapy so far. Karen's a trialist intensivist and also an endocrinologist, which puts her in a very interesting position. Let's hear whether Karen would treat this patient with thiamine, vitamin C and hydrocortisone.
Well, for a 27-year-old previously healthy person involved in a traffic accident, personally I wouldn't currently recommend a thiamine, vitamin C and steroid replacement regime. Even if she's in vasodilatory shock at the ICU with pneumonia. However, I would check if maybe she has had a history of topical steroids for asthma, for example, and then I would indeed give her steroid hydrocortisone treatment in stress doses over a few days, but not the full package, because I personally believe that the data do not currently support this approach. So bye-bye everyone from Graz.
So back to me again. What do I think? Would I use the Metabolic? Not yet. The design of the study, being single-centre retrospective before and after study, is at high risk of confounding. And so I'll be waiting for the results of the multiple randomized controlled trials before I start using this therapy.
Steroids, no steroids, metabolic cocktail, or no metabolic cocktail.
Very good. Well done. Well, just when we think we're coming to the end of our road to Resus experience, there's been an interesting development in our patients' care.
So, in the stocking room, in the stocking cabinet, the closet for the ICU, there's a vat, a barrel of vitamin C and a clot fire. All of the patients had to be evacuated. There are these holding areas. You should be another ICU. You're the family member acting on behalf of our patient who isn't yet able to speak for herself, and you're approached by a hospital administrator to make a choice.
Your choice here is very interesting. You have to choose between two intensive care units, which are identical, except for one thing: the intensive care physician in charge. In one, you have Dr. John Jones. He's a 45-year-old intensivist with an impeccable record of safety who only went to the best institutions. In intensive care unit number 2, you have Dr. Julie Jones, who is a 45-year-old intensivist with an incredible record of safety and also went to the same institution and graduated the same year as Dr. John Jones.
So the only discernible difference between them is that one is a man and one is a woman.
Fortunately for us, we have some maybe experts-ish on this very issue that I think we should hear from.
Aloha. Women of the sisterhood, please forgive me. I am representing those who believe that we should go and see the men. And I'm very pleased to be here debating against the champion masturbator himself, Roger Harris. So I am absolutely going to admit my family member to the ICU being controlled by men, and I'll tell you why. Roger's about to tell you that what those studies are going to say is that women are more consultative. Women are more focused on preventative medicine. Women are more likely to take their time and duration in their consult. Women are more likely to have better communication. Women are more likely to remind you of your annual checkups. But my family member is critical ill and I don't need Reiki or a reminder for a pap smear. I need someone who is going to be 100% in control. And if you look at the research, the SIM stuff shows that male-led CPR goes better than female-led CPR. And the reasons for that is that women still don't know how to carry on in resus roles. They still don't know how they want to lead themselves within medical teams. Forgive me. And the biggest thing for me is I don't know where she is in her cycle. Because let's face it, all women are completely hysterical and hormonal, and anything that happens in the world is probably due to period or, menopause, something like that, and they're too erratic. The other thing is that women are too distracted. So despite the fact that we now have complete right to work in whatever field that we want to, women are still carrying 80% of the household chores, 80% of the childcare chores, and men will never understand what the mental load for us when we're at work. Just before I came on stage on Wednesday to give my plenary talk, the dentist rang to say that my child had missed his appointment, and I'm pretty sure there's no man in the audience who had to do a menu plan, iron school uniforms before attending SMAC. And that's why I want a men-led physician, because he's got nothing else on his mind but the task at hand. Good luck to you, masturbator champion. Lube up.
You would think I would have some control over these events. I don't know how you guys conned me into this. I knew that I was in trouble. I'd like to begin by apologising to the representatives of the New England Journal and the George Institute that are here today, observing our conference.
Whoops.
Yeah, goodbye, Coda. It was a great idea. Okay, so I'm amazed you read those papers. But I guess those papers make some interesting points, and there is a body of retrospective cohort evidence that would suggest that female doctors are not better than male doctors per se, but they may offer increased, lower risk of mortality to female patients in particular. And I think that's got some plausibility about it, in the sense that in our modern age of precision medicine, I think we're learning more and more that patients react with diseases in different ways. And that's not just because of their general genetics, that's often because of genetics related to their gender. And I think also that they don't just react to the disease, they actually react physiologically, they react to the disease in an emotional and very personal way. So women probably experience diseases and react to those diseases differently to men. So the way that we treat women and men really probably should be different. And women, I think, would appreciate the perspective as other women and advocate for them better. I think that's quite plausible.
Can I just say, I cannot wait until we never have a gender debate again, because what we are looking for is fantastic, skilled doctors, and that what the real research shows is that diversity of all aspects in a team is what brings great patient outcome.
I was supposed to have the last say. Typical woman, yeah. So, could I just finish by agreeing with that? in that what the evidence does also show that male doctors that work with female doctors perform better as doctors. And that's not just a gender thing, that's a diversity thing. So medical teams that have minority groups represented within their workforce perform better as well. That's the end.
I actually just said that.
Someone turn their microphone off, please. Excellent. That was enlightening. All right, so your last and final vote for your Road to Resus experience. Who are we going to choose? Man or woman? All right, friends. Thank you. We just wanted to say thank you for this opportunity, and thank you to so many people that participated in our Road to Resus journey, particularly to our friends in AV and the amazing Jason Vandervelde for all of our videos and everyone who sent those in. So thanks to them, and thanks to all of you for your participation. It's been awesome. Thanks.